approach quantifies each risk factor appropriately, and it also gives you the idea that a woman can develop preeclampsia at 24 or 28 or 32 weeks in a unified way, so that mathematically you can estimate for each woman the risk of developing preeclampsia at any given gestational age. The risk factors are the traditional risk factors. The shift to the left, and therefore the increased risk, increases with advancing maternal age. The graph is shifted to the left, therefore the risk is increased. It increases with maternal weight. Maternal height is protected, so it shifts the graph to the right. Women that are Black and South Asian have a higher risk. Women who developed preeclampsia in their previous pregnancy have a higher risk. And those that did not develop preeclampsia have a lower risk. Women whose mother had preeclampsia have increased risk, and women that conceived by in vitro fertilization also have increased risk. The strongest risk factor for developing preeclampsia in this pregnancy is chronic hypertension, followed by diabetes and systemic lupus erythematosus. So, when we take a history for a person, we can use this approach to individually quantify the risk. Once we have the individual patient risk, this is the prior risk, this is the starting risk, and then light with downs. Once we have the maternal age risk, we can modify this by the results of the various tests. Now, the various tests. The first one is the mean arterial pressure. Here, I illustrate how you best measure the mean arterial pressure. A woman must be rested for up to 5 minutes in a comfortable sitting position without the legs crossed, with the arms supported at the level of the heart. And then we select the appropriate calf. If the arm is small, normal, or large, depending on the mid-arm circumference. And then we take 4 measurements, 2 from each arm, and then we take the average of these 4 measurements. The second biophysical test is the uterine artery pulsability index. In the first trimester, but also in the second and the third, you can use transabdominal ultrasound, or you can use transvaginal ultrasound to make these measurements. With transabdominal ultrasound in the first trimester, you align the transducer longitudinally, and then you tilt it on either side of the cervix to see the uterine arteries at the level of the internal cervical os. with the external iliac arteries. You use color Doppler to identify the vessels, and then you select pulse Doppler with a sampling gate of about 2 millimeters to cover the whole vessel, and then you image the vessel at an angle of inclination of less than 30 degrees, and you make sure that the peak systolic velocity is more than 60 centimeters per second, and then you take a measurement from the left and a measurement from the right, and the mean PI is the average of the two. The biochemical measurements are placental growth factor and papain. These graphs show the normal ranges, which are now expressed as multiples of the median. So normal is always 1, the blue line, and the black dots are from women that developed preeclampsia. And you can see that in those that develop preeclampsia, the uterine artery pulsatility index and the mean arterial pressure are increased compared to the normals. But this increase is proportional to the severity of the disease, because in women that develop severe early onset preeclampsia requiring preterm delivery, the levels are very high, whereas with those that develop late term preeclampsia, the levels often are normal. The two biochemical measurements are placental growth factor and pregnancy-associated plasma protein A, and the levels of these chemistries are reduced, and the decrease is proportional again to the severity of the disease, and it is greater the earlier the gestation for the development of the disease. So, as in the case of Downs, we calculate the prior risk based on these maternal characteristics, and then we multiply this risk by the measurements of the uterine artery pulsatility index, mean arterial pressure, placental growth factor, and papain. And now we can detect about 75% of the cases that will develop preterm preeclampsia, and about 55% of those that develop total or mainly term preeclampsia. So the ability to predict preeclampsia in the first trimester depends on the severity of the disease. The test is very good for early disease, and therefore, if we want to identify cases that will develop late disease, we may have to reassess them later on in pregnancy. But the question is, why is it important to identify at 12 weeks in pregnancy women that will develop preeclampsia? The answer is quite simple, because if we want to prevent preeclampsia, the only method that we have available at the moment is the use of low-dose aspirin. And extensive studies over the last few decades have shown that if you give aspirin after preeclampsia, fetal growth restriction, and perinatal death is much less than if you give aspirin starting from 12 weeks, where the reduction in the rate of preeclampsia is more than 50%. The reduction of fetal growth restriction and the reduction of perinatal death all are more than 50%. Whereas if you give the treatment after 16 weeks, it's too late and it is not useful. That is the rationale for early prediction of the disease. We are doing a study now where it's a multi-center study in Europe where we are going to screen more than 30,000 women in the first trimester and then decide what's their risk and then randomize them into placebo versus aspirin 150 milligrams per night, with the hope that we will reduce the rate of preeclampsia by 50%. The next time I speak to you, in Egypt, I will be presenting you these results. So that is the rationale of the first semester screening for preeclampsia. Identify a high-risk group that could benefit from prophylactic aspirin to reduce the prevalence of the disease. Now, in the cases that have not received treatment, or we are seeing later on in pregnancy, or that have received treatment, but the aspirin has not prevented the disease, the objective is to identify the high-risk groups so that we can monitor them with the objective of diagnosing severe disease as early as possible so that we can decide what is the best time and method of delivery to improve perinatal outcome. So the objective of screening at 12 weeks is prediction and prevention. The objective of screening later on in pregnancy is prediction for monitoring to prevent complications rather than to prevent the incidence of the disease. We have carried out extensive research with a combination of biophysical and biochemical markers at 22 and 32 and 36 weeks. And we are beginning to develop a model where at 22 weeks, with a combination of history, mean arterial pressure, uterine anticoagulability index, and placental growth factor, we can divide the population into three groups. A very low risk group that may not require any further assessment, a very high risk group that would require regular follow-up starting from 24 weeks, and the moderate risk group that we have to reassess in the 36th week of pregnancy. So here we have a scheme. Screen at 22 weeks, very low risk group, nothing. Moderate risk group, review at 26 weeks. High risk group, review at regular intervals, and again at 32 weeks. If we did that, with these sort of numbers, we should be able to identify all or certainly nearly all cases of preeclampsia. With this, I also suggest of what is it that we do for the high-risk group. We assess them, and then we divide them up again into two risk categories. A very high-risk category group, either at 22 weeks or at 32 weeks, that need to be seen every 2 weeks. And the low-risk group that can be reassessed 10 weeks have no risk of perinatal death. Others are small because they have fetal abnormalities or congenital infection, and the management of those cases is different. But some will be small because of placental insufficiency. And some of these babies will die either before or soon after birth. And in the long term, they can suffer from neurological and other handicap. The traditional approach to identifying these groups has been through abdominal palpation, and you have nice diagrams like this of how you feel with your fingers the fundus, and how the height of the fundus by palpation defines normality or abnormality in growth in months. This is what is used in Egypt, and this is what is used in every hospital in the United States and in England. An even more sophisticated approach is to use a measuring tape to measure the symphysis fundal height. And the British government has recently announced, because of the elections, this major breakthrough that all women in every hospital must have their uterus measured with a measuring tape. And then I started laughing. Because this is what my father was using in his village in Cyprus about 50 years. This approach of palpation and symphysis fundal height measurement can identify at most 1/3 of the cases that will have severe growth restriction, even leading to stillbirth. More than 70% of the cases of severe growth restriction are missed. The British government wants us to say congratulations for wanting to introduce a stupid method of screening that will identify the small minority of the cases that can die. A more logical, of course, approach to identifying the higher risk group is similar to that of screening for preeclampsia. You combine factors from the mother's history together with the measurement of the mean arterial pressure, the uterine artery pulsatility index, and the measurement of PABA and PLGF. And now we can identify the majority of cases that can potentially result in severe growth restriction in stillbirth. And in the same way as with preeclampsia, we can try to reduce the prevalence of this disease through aspirin or education on smoking cessation or continuing studies on the potential value of antithrombotic medication. So screening at 12 weeks is important because through screening and treatment we can reduce the prevalence of the disease. However, it is important to continue to monitor and identify the high-risk pregnancies in the late second and third trimesters, not with the intention of prevention now, but with the intention of defining the best time and place for delivery. And the major study in Sweden has shown that in the pregnancies identified as being small before, rather than the ones where they were identified after birth, the prevalence of adverse outcome in the prenatally diagnosed cases was less than half than those that were missed. So